Good evening, everyone. Thank you for joining us for At-Risk Foot Care, Proper Evaluation, Treatment, and Documentation. We're very excited to have Dr. Warshaw here with us to give this talk. He's got immense experience in the field and gives presentations on this particular topic quite often. It is one that people have a lot of questions about. If you have any questions tonight during the presentation, there is a little box on your Zoom meeting app that says Q&A. You can type in questions there and I'll be reading them out at the end, as well as the questions that were submitted ahead of time. So without further ado, it's Dr. Warshaw.
Hi, everyone. I'm pleased to have the opportunity to speak before you. The topic tonight, at-risk foot care, is probably one of the most important topics that pertain to most podiatrists, very simply because this is probably the number one thing that we see patients for and treat patients and bill for performing the proper evaluation, treatment, and documentation. I hope you find this to be very helpful in doing your daily treatment regimen with your patients. Routine foot care, by definition, is described as the cutting or removal of corns and calluses and the trimming and debriding of toenails. For Medicare purposes, this routine treatment of the feet is not a covered service. As a rule, it is not covered and is referred to as non-covered routine foot care. It's non-covered, the patient receives the service, they have to pay for it. However, under certain limited conditions, Medicare will pay for this routine treatment of the feet. And in those situations, the routine foot care is then referred to as covered routine foot care. So what we're going to discuss, at least initially, is going to be covered versus non-covered routine foot care and how to bill Medicare. And it's very important to note, do not bill routine foot care using an E&M code or what many people consider to be an office visit. You have to bill the appropriate CPT code. Even though you're examining the patient, you're working the patient up in order to appropriately document what is going to be performed that day, you cannot bill routine foot care using an E&M code. As far as non-covered routine foot care is concerned, again, Medicare does not pay for routine foot care except in very specific limited situations. Since we are not required to bill Medicare for any non-covered condition, you do not have to bill Medicare for a non-covered routine foot care service. It is necessary, however, to inform the patient in advance of any treatment that is not covered. You need to have the patient sign an advance beneficiary notice of non-coverage, known as an ABN, which notifies the patient in advance that they are obliged to pay for the service. If the patient at that time insists that you send this claim to Medicare, even though they had to pay for it and they signed an ABN, you would then, if the patient insists, you bill the appropriate routine foot care CPT codes appended by the GA modifier to inform Medicare that what was performed was a non-covered service. Here are the routine foot care CPT codes. 11055 is paring or cutting of benign hyperkeratotic lesion, for example, a corner or callus, And this would be one lesion, a single lesion. I do want to interject one point. When I review medical records or I perform audits for physicians or on behalf of an insurance company or Medicare, very simply, when a hyperkeratotic lesion is identified and it's trimmed or pared or cut, all you really need to do is identify this lesion as a corner or callus instead of some sophisticated hyperkeratotic lesion. Keep it simple. Simple is best. 11056 is paring or cutting of benign hyperkeratotic lesions. For example, a corner or callus, 2 to 4 lesions. 11057 is paring or cutting of benign hyperkeratotic lesions. For example, corns or calluses, more than 4 lesions. 11719 is trimming of non-dystrophic nails, any number. Well, people ask, what is a non-dystrophic nail? Well, in reality, a non-dystrophic nail is a normal nail. And in an at-risk patient, the trimming of a normal nail can be an issue, because if this nail is trimmed by the patient or an untrained professional, this could result in an infection or loss of limb. 11720 is debridement of a nail or nails by any method or methods, 1 to 5 nails. 11721 is debridement of nails by any method, 6 or more. And then we have G0127, trimming of dystrophic nails, any number. Well, what's a dystrophic nail? A dystrophic nail is obviously not a normal nail, and it's not a mycotic nail. It can be thick, it can be ridged, it can be misshapen. It's an abnormal nail, but not a mycotic or fungus nail. As far as covered routine foot care, when a patient has a specific systemic disease, either a metabolic, vascular, or neurologic disease, and the patient requires the services of a physician, either a podiatrist, an MD, or a DO, Medicare will pay for routine foot care. Medicare will pay for routine foot care if the patient's systemic disease has resulted in either severe circulatory embarrassment or bad circulation, or areas of diminished sensation or numbness in the patient's leg or foot. Here is a very important point. Please access the LCD or the local coverage determination of your Medicare carrier for routine foot care for a list of the systemic diseases that qualify routine foot care service for Medicare payment. Most Medicare Part B carriers, Medicare administrative carriers, have a local coverage determination or a policy for routine foot care or routine foot care and the debridement of nails. The one Medicare administrative carrier that does not is Noridian. What Noridian advises the providers to do is access the national coverage determination as put out by CMS, Centers for Medicare and Medicaid Services, for that version of routine foot care services. The patients that qualify for coverage under covered routine foot care are referred to as at-risk patients. When you look at the list of systemic diseases that qualify routine foot care for payment by Medicare, either in the local coverage determination of the specific Medicare administrative carrier or the national coverage determination of CMS, there are two groups of systemic diseases. There are the asterisk systemic diseases and the non-asterisk systemic diseases. As far as the asterisk systemic diseases are concerned, an asterisk systemic disease, patients with one of these diseases designated by an asterisk must be under the active care of an MD or a DO for that specific systemic disease. Active care means that the MD or DO is treating the patient for that disease and has seen the patient at least once in the past 6 months for that systemic disease prior to the foot care encounter. This is referred to as the active care requirement. I'd like to add one more point to this paragraph. The patient doesn't necessarily only have to be under the active care of an MD or DO for that specific systemic disease. If the provider that is treating the patient for that systemic disease is a nurse practitioner or a physician's assistant, that would qualify as well. When a podiatrist provides a routine foot care service, and again, we remember these CPT codes, 11055, 5657, 11719, 11720, 11721, or G0127, to a patient with an asterisk systemic disease, they can bill and be paid by Medicare, but must include specific designated information in the medical record and on the billing claim form. Include the following in the medical record if the patient has an asterisk systemic disease. This is in the medical record. The name of the MD or DO or NP or PA treating the patient for the systemic disease. The date last seen by the MD or DO for the systemic disease. They want the day, the month, and the year. They want you to state the systemic disease. Yeah, I understand it's repetitive and it's kind of bizarre, but every patient encounter needs to be documented and be able to stand on its own with no effect on what happens afterwards and no bearing on what happens previously. With very few exceptions, when a physician is audited, they don't ask for entire medical records, they ask for specific dates of service. So if the patient is diabetic, patient has diabetes. If the patient has a peripheral vascular disease, that needs to be stated. You also need to state in the medical record the associated complication or complications resulting from that systemic disease. In reality, these are the class findings that lead you to select the appropriate Q modifier that is appended to the CPT code or codes that are billed. Lastly, the documentation for the podiatric diagnosis or diagnoses, including the treatment plan, need to be present in the medical record. You need to include the following on the billing claim form: the name of the MD or DO treating the systemic disease, the NPI of the MD or DO treating the systemic disease, the date last seen by the MD or DO specifically for the systemic disease, the day, the month, and the year. Remember, this has to be within 6 months of the podiatric encounter. If the patient comes in and saw their doctor 5.5 months ago for bronchitis, but has not seen their MD or DO for the specific systemic disease, such as diabetes, within 6 months, then they do not qualify for coverage. You then list the systemic disease code of the treating MD or DO, the ICD-10-CM code, the podiatrist podiatric diagnosis or diagnoses ICD-10-CM codes, and then the appropriate CPT codes are listed, and again, 11055, 11056, 11057, 11719, 11720, 11721, or G0127 are appended by the correct Q modifier, either Q7, Q8, or Q9. The Q modifiers, remember, are documented in the medical record as the associated complications resulting from the systemic disease. These are the class findings. We will get to those soon. What about the non-asterisk systemic diseases? A patient with a non-asterisk systemic disease does not need to see the MD or DO within 6 months of the foot care encounter. I know when we bill, we put down a date last seen, but once again, if the patient has a non-asterisk systemic disease, the patient does not need to see the MD or DO within 6 months of the foot care encounter. The active care requirement does not apply. The date last seen is not a requirement. The systemic disease diagnosis and subsequent treatment of the systemic disease can be made by an MD or DO as appropriate. The simple indication of a systemic disease without documentation is not adequate. Podiatrists are limited scope practitioners and can't treat systemic diseases. A podiatrist can treat the manifestations, complications, or end results of a systemic disease when they appear in the treating area of a podiatrist, the foot and the ankle. Include the following in the medical record: the name of the MD or DO treating the patient for the systemic disease. This can be problematic. Very often, the non-asterisk systemic disease entity that we see patients for is peripheral vascular disease. And the number one code that is used is peripheral vascular disease, unspecified, I-73.9. Very often, the name of the MD or DO that is put down in the medical record is the primary care physician. We'll get back to that in a moment and what the issue is. You need to list the systemic disease. You need to list the associated complications resulting from the disease. These are the class findings, again, that lead you to select the appropriate Q modifier that is appended to the CPT codes that are billed. Then, of course, the documentation for the podiatric diagnosis or diagnoses, including the treatment plan. Include the following on the billing claim form. Now we'll get back to this MD or DO thing. The name of the MD or DO treating the systemic disease. This can't be the patient's primary care physician unless the primary care physician is actually treating the systemic disease. Think about this for a moment. We're stating that the patient has a peripheral vascular disease entity such as I-73.9, PVD, peripheral vascular disease, unspecified. We're putting down the name of the primary care physician in the medical record and on the billing claim form that the primary care physician is treating the patient for peripheral vascular disease. What if there is an audit and the doctor that is audited is not the podiatrist, but it's the primary care physician, because they find that this physician is listed as the treating physician for peripheral vascular disease for many patients? Well, this is going to create a very big issue, and the person that's going to be thrown under the bus is not going to be the primary care physician. It could very likely be us because we listed that doctor's name down. I think it's imperative to let the Medicare carrier know not only that the patient is being treated by the primary care physician for this systemic disease, but I think it's also important to let the primary care physician know that he or she should be treating the patient for the systemic disease. And I'll get back to that in a few moments and give you an example of a letter that works very, very well. You then on the claim form need to include the NPI of the MD or DO treating the systemic disease. Once again, the ICD-10-CM code for the systemic disease of the treating MD or DO. The podiatric diagnosis or diagnoses ICD-10-CM code or codes. Again, the appropriate CPT code or codes, and we know what they are, and they need to be appended by the correct Q modifier, either Q7, Q8, or Q9. The Q modifiers are documented in the medical record, again, as the associated complications resulting from the systemic disease. These are the class findings. Here are the podiatric diagnosis codes. B35.1 is dermatophytosis of a nail or onychomycosis tinea unguum. L60.2 is onychogryphosis or hypertrophic nails. L60.3 is nail dystrophy or dystrophic nails. L60.8 is other nail disorders. L60.9 is nail disorder unspecified, and L84 is corns and calluses. The next slide is a diagnosis to procedure linkage. If the patient has mycotic or fungal nails, the ICD-10-CM code is going to be B35.1, and the associated CPT codes would be either 11720 or 11721. If the ICD-10-CM code is either L60.2 or L60.3, the CPT code, or in reality, the HCPCS Level 2 code would be G0127. If the ICD-10-CM code is either L60.8 or L60.9, the CPT code is 11719. And if the ICD-10-CM code is L84, then the CPT code will be either 11055, 11056, or 11057. Class findings. The class findings are what we use to select the appropriate Q modifier that is appended to the CPT code or codes that are billed. The Q7 modifier is used on a claim form if there is a Class A finding. There is only one Class A finding, a non-traumatic amputation of a foot or an integral skeletal part of the foot. Well, what's an integral skeletal part of the foot? Well, from a personal standpoint, any amputation is integral to me. But from a Medicare standpoint, an integral skeletal part of the foot would be not necessarily a toe. If the patient has a toe amputated, that really does not qualify for the Q7 modifier. If a patient has a non-traumatic amputation of a toe, if you're not able to find enough class findings or the appropriate class findings to justify the use of the Q8 or the Q9 modifier, then you're not doing your job. So what is an integral skeletal part of the foot? Well, obviously, if there is a BK amputation, there is a mid-tarsal amputation, it's an integral skeletal part of the foot. If there is a first ray amputation or a fifth ray amputation, that too would be examples of an integral skeletal part of the foot. What about the Class B findings? You use the Q8 modifier on the claim form if there are two Class B findings. The absence of a PT or posterior tibial pulse. Absence does not mean the patient doesn't have the pulse. It means for whatever reason, it's non-palpable. So if there is a non-palpable posterior tibial pulse, that makes up one Class B finding. If there is a non-palpable dorsalis pedis pulse, that is also one Class B finding. If both posterior tibial pulses are non-palpable, that only generates one Class B finding. If both dorsalis pedis pulses are non-palpable, that still only generates one Class B finding. In order to achieve two Class B findings by non-palpable pedal pulses, the two non-palpable pulses must be non-palpable on the same foot. For example, a non-palpable dorsalis pedis pulse and a non-palpable posterior tibial pulse on the right foot generates two Class B findings. Any three of the following advanced trophic changes generates one Class B finding. Hair growth decreased or absent, nail changes, pigmentary changes, skin texture thin and shiny, skin color rubor or reddened. What about the Class C findings? You use the Q9 modifier on the claim form if there is one Class B and two Class C findings. Here are the Class C findings: claudication, temperature changes, specifically cold feet, edema, paresthesias, and burning. Here are some coding examples. If the patient has corns and calluses that are trimmed or paired or debrided, it would be 11055, 56, or 57 with the appropriate Q modifier appended. If the patient has 6 or more mycotic nails that are debrided, you bill 11721 with the appropriate Q modifier appended. If the patient has 1 or more normal nails, 11719 would be billed with the appropriate Q modifier. If the patient has 1 or more dystrophic nails and they are debrided or trimmed, G0127 would be the appropriate code to bill with the correct Q modifier appended. Well, what if the patient has 1 or more corns and calluses and 5 or more mycotic nails? It would be on line 1, 11055, 56, or 57 with the appropriate Q modifier appended, and on line 2, it would be 11721 with the 59 modifier appended, as well as the appropriate Q modifier. If the patient has 1 or more corns and calluses and 1 or more normal nails, or say all of the nails are normal, 11055, 56, or 57 goes on line 1 with the appropriate Q modifier appended. 11719 with the 59 modifier appended, along with the appropriate Q modifier, would go on line 2. If the patient has 1 or more corns and calluses, 11055, 56, or 57 goes on line 1 with the appropriate Q modifier. And if the patient has any number of dystrophic nails, G0127 with the appropriate Q modifier goes on line 2. If the patient has 1 or more corns and calluses, 11055, 56, and 57 goes on line 1 with the appropriate Q modifier. If the patient has, for example, 6 normal toenails, 11719 goes on line 2 with the 59 modifier and the Q modifier appended. If the patient has, say, 4 or 5 mycotic nails, that 11720 would go on line 3, appended by both the 59 modifier and the Q modifier. If the patient has 1 or more corns and calluses, 11055, 56, or 57 goes on line 1, appended by the appropriate Q modifier. If they have, for example, 5 mycotic nails, 11720 goes on line 2, appended by both the 59 and the Q modifier. And if the remaining 5 toenails are dystrophic, G0127 goes on line 3, appended by both the 59 and the correct Q modifiers. Now, we've just gotten back to this now. I said we're going to return. So you have a patient that has PVD, and you bill I-73.9, PVD or peripheral vascular disease, unspecified. The name of the doctor that you have recorded in the medical record and on the billing claim form that is treating the patient for the peripheral vascular disease is the primary care physician. Or maybe it's an interventional cardiologist, or perhaps even a vascular surgeon. You need to advise this doctor that, number one, they need to treat this patient for that particular situation, which is peripheral vascular disease, and they need to follow up that they have done so. You don't need a date last seen, but they do need to be part of the food chain. So this is the letter that you would send. And again, this is a form letter. This is just an example, a suggestion. The date of the letter, the name of the patient. Dear doctor, the doctor that you have put down as the doctor treating the peripheral vascular disease, for example, in the medical record and on the billing claim form. We have a mutual patient by the name of whomever. Based upon my lower extremity physical examination, I have found him or her to have peripheral vascular disease based upon your physical findings that you have documented in the medical record. I will be more than happy to take care of our mutual patient's foot care needs, but I request that you follow up and treat the peripheral vascular issues. Thank you for your attention to this matter. Sincerely, you. You fax this letter to the doctor who you recorded in the medical record and on the billing claim form. You don't give it to the patient to take to the doctor. You don't mail it. You fax it. The reason you fax it is very simple. You get instant confirmation when it was sent, who it was sent to, and when it was received. When those papers come out of the fax machine, you then scan all of them into the electronic medical records of that patient. Here is a segue slide. We're talking specifically about mycotic nail debridement. Mycotic nail debridement is covered two ways. We just spoke about the routine foot care exception for the at-risk patient. In order for this patient to be covered for the debridement of mycotic nails, the patient has to have class findings. There has to be a covered systemic disease. The patient has to have mycotic fungal toenails. And here's an important point. The mycotic toenails don't have to be symptomatic. Just the fact that the patient has mycotic toenails is sufficient, because if this at-risk patient attempted to cut his or her own toenails or had an untrained professional do so, they run the risk of an infection or loss of limb. That is why it's covered. So if you have a patient that is covered through the routine foot care exception, don't put down the nails are painful. It's not necessary. It's one or the other, not both. The other way that it's covered is in the otherwise healthy individual. An otherwise healthy individual does not have class findings, and they don't have a systemic disease that is covered. But they do have mycotic fungal toenails. And the reason that they are covered is based upon symptomatology. They're symptomatic, and we'll touch upon that now. Mycotic nail debridement in the otherwise healthy individual. Medicare considers the treatment of mycotic nails a covered service only in very specific limited situations. The presence of a fungus infection of the nail does not automatically qualify for Medicare payment. Unless the fungus infection in the nail requires debridement because it caused the nail to be abnormally thick, which resulted in either pain or a secondary infection or a marked limitation of walking, the treatment service is considered simply a nail trimming and is not payable by Medicare. It would be classified as non-covered routine foot care. Mycotic nail services in the otherwise healthy individual are payable in two groups of patients, an ambulatory patient and in a non-ambulatory patient. For an ambulatory patient, the patient must have a marked limiting of walking due to the thickness of the fungus nail. Not only do you need to identify and document which of the toenails are fungus and thick, but more importantly, which of those fungus toenails are causing this patient to have a marked limiting of walking. I mean, let's be realistic. How many patients do you actually see in your office have toenails that are so thick it limits the way they walk? I would suspect not very many. But here's the biggie. Or the patient must suffer from pain due to the thickness of the fungus nail. Not only do you have to identify which of the toenails are fungus, but which of those toenails that are identified as being mycotic or fungus specifically are painful when the doctor pushes down on them. Patients aren't dumb. Once they realize that if they say their toenails don't hurt, they have to pay, they're going to say they hurt. The only appropriate way to document this is through your physical examination. Which of the toenails are fungus, and which of those fungus toenails, when the doctor pushes down on them, are causing the patient to say ouch, or withdraw, or retract their foot because of the pain. Or the patient must suffer from a secondary infection due to the thickness of the fungus nail. So not only do you have to identify which of the toenails are mycotic or fungus, but which of those toenails have a secondary infection, such as a paronychia or an onychia, resulting from the onychomycosis. And there must be documented clinical findings to substantiate the fungus diagnosis. For the non-ambulatory patient, it's really quite simple. It's exactly the same as for the ambulatory patient, but the patient suffering from pain due to the but the patient having a marked limiting of walking due to the thickness of the fungus nail is moot because the patient is non-ambulatory anyway. Include the following in your medical record. Medicare requires adequate documentation to allow payment for mycotic nail services. You need to clearly indicate in your medical record the following information. This needs to be documented for each of the affected toenails. When you read the local coverage determination of the specific Medicare administrative carrier, or you read the national coverage determination, it clearly states that each of the affected toenails need to be individually identified. Which of the toenails are painful upon palpation, and or which of the toenails have a secondary infection, and or which of the toenails are causing a marked limitation of ambulation. And you need to document clinical findings indicating the fungus infection. You don't need a positive fungus culture. You don't need a positive KOH test. But you do need to mention the following. Is the toenail thick? Is it discolored? If it's discolored, what is the discoloration? The odor thing is kind of weird because how do you know which of the toenails is actually malodorous? What is the texture of the toenail? Is it crumbling? Is it flaking? Is it cracking? Is it splitting? Is it scaling? Is there debris beneath the toenail, subungual debris? But here is the big point in this code set that many of us miss. When you read the LCD or you read the NCD, it clearly states that the patient needs to be on an active treatment plan for the fungus infection. In the otherwise healthy individual, Medicare firmly believes that if the patient was on an active treatment plan for the fungus infection, hopefully the fungal infection will go away. But at the very least, the symptoms will go away. And if the symptoms go away, they no longer have to pay. Well, what's an active treatment plan? Well, you can prescribe an oral antifungal medication. You can prescribe a topical antifungal medication. You can have the patient apply an over-the-counter topical fungal medication, or you can place the patient on a general treatment plan for toenail fungus, something like this. Patient instructed to keep their feet clean. Patient instructed to dry between their toes. Patient instructed to change their socks and their hose and their shoes daily. And patient instructed to apply a topical antifungal medication to the affected nails on a regular basis. If the patient's condition meets the published very specific limitations for payment for fungus nail services in the otherwise healthy individual, if you are debriding 5 or fewer, it's 11720. If it's 6 or more, it's 11721. As far as what goes on your claim form, your primary diagnosis is always going to be B35.1, dermatophytosis of nail or onychomycosis. As far as the secondary diagnosis, if the patient is having a significant difficulty in walking due to the thickness of the fungus nails, it's R26.2. If the toenails are painful on the right foot, it's M79.674. If the toenails are painful on the left foot, it is M79.675. If there's a secondary infection affecting the toenails on the right foot, or the toes on the right foot as a result of the onychomycosis, it's L03.031. If it's on the toes of the left foot or a toe of the left foot, it's L03.032. Important for documentation for mycotic toenails. All of the affected toenails need to be identified. A thorough description of the fungal infection needs to be documented for all of the affected toenails in question. The secondary qualifying diagnosis, pain, difficulty with ambulation, or secondary infection needs to be documented for all of the affected toenails in question. The instrumentation used needs to be documented. For example, the toenails were debrided using a nail nipper and an electric file. The word debridement needs to be used. You can't say trim, you can't say filed, you can't say reduced. It has to say debridement. Aside from the fact that they're telling you it has to say debridement, let's face it, the operative word in both CPT codes 11720 and 11721 is debridement. Well, that takes care of my part. Are there any questions?
Okay, so we do have a few questions. We're going to start with the ones that were sent in ahead of time. We have
Okay.
one that asks, how often does Medicare allow at-risk foot care to be seen for their routine foot care?
The rule is no sooner than every 60 days. So assuming they meet the criteria for at-risk foot care or for symptomatic mycotic nails, it cannot be sooner than 61 days.
Okay. Just a reminder to our listeners, if you want to ask a question, you can do so in the Q&A section. If you hover over the presentation with your mouse, it should pop up and you can type it in there or in the chat. The next question is, and you may have touched on this, how would you bill covered nails and callus with tinea infection?
Well, if it's a tinea infection, like athlete's foot, that has nothing to do with routine foot care. And you would bill it, for example, if you prescribed a topical antifungal cream to put on the patient's foot, then you would bill it with the appropriate E&M service. But as far as a fungal infection or a tinea infection affecting the toenails, I think we pretty much have covered that.
Okay, this is just kind of a housekeeping question. Can the presentation be sent via email? Yes, I have the Dr. Warshaw's presentation and I can send it out to people. So if you would like a copy of the presentation, you can put that in the chat or in the Q&A and I can send it to you. We will also be posting the full presentation with Dr. Warshaw's audio on our live learning center within the next couple of weeks. And then next question, and I know that you said there was somewhere people could check for qualifying diseases, so I'm not sure if this is something you can speak to, but someone asked, is diabetic with neuropathy but no other at-risk findings covered by Medicare, and what modifiers should be used?
Well, there are two ways to look at this. If the patient has diabetes with some level of neuropathy, when you read the LCD of your Medicare carrier, it will tell you, number one, if the patient does have vascular class findings, then you would append the appropriate, generally Q8 or Q9 modifier. But if the patient has significant peripheral neuropathy as a result of the diabetes, you would use the appropriate diabetes systemic disease ICD-10-CM code, like for example E11.42, and you wouldn't need to append a Q modifier. But I would strongly suggest that you read the LCD of your Medicare carrier, because your carrier will specifically tell you if you're going to use a neurological situation, exactly what your documentation has to be in your medical record to not use the Q modifier.
Okay. We now have another question. If the patient is not at risk, 3 fungal nails and 7 clear nails, how do you bill 11720 covered plus 11719-59 not covered? Need ABN for the 7 trimmed nails?
Well, let's look at it this way. 11719 is for the trimming, for all practical purposes, of normal nails. If this patient is not an at-risk patient, does not have a qualifying systemic disease, and obviously class findings, but the 3 fungal or mycotic toenails are symptomatic, you would bill 11720. Now, do you have the right to collect for trimming those other nails? Well, you really do, and if you're going to charge the patient for trimming those other 7 nails, then they're going to have to pay, and an ABN would be appropriate.
Okay, that is all the questions that have been submitted. I'll linger a bit just in case anyone is typing out one last question to get in. In the meantime, Dr. Warshaw, thank you for your time and for your expertise on this. Like I
My
said,
pleasure.
thank you. Like I said, we will be posting this to the Live Learning Center in case you know anyone that couldn't make it tonight. You can recommend they check it out there. And it looks like we haven't gotten anything else in, so I'll go ahead and call it a close. Thank you, everyone.
Good night, everyone.